Thank you, everyone. Thank you to the Gulf Heart Society for this wonderful meeting and for the invitation to speak with you for a while about revascularization in cardiogenic shock after MI and in particularly after ROSC. So first of all, I have to thank all my colleagues that came before me because they already paved the way for my speech, and many things will be already clear in the auditor minds. This one, maybe? Okay. So this is the outline of my presentation, and most of this topic has already been well taken by my colleagues. Maybe what is not arise in their talk, it's what is the golden day of cardiogenic shock and what's the importance of protocols in cardiogenic shock management. So already we know that mortality in cardiogenic shock is extremely high, at least 40%, we can say. This is based on the latest data that we can find both in the Northern America, you can see on the left side of the slide from Osman, and even in Europe. Jerkerman in the European Heart Journal 2 years ago, they reported the Swedish cardiac resuscitation registry, showing that the mortality improved in the early 2000 years. In the last 10 years is almost stable in out-of-hospital cardiac arrest. And what it improved is the number of cardiac diseases as underlying cause in the last 30 years. That's most likely not because of the interventional cardiology, but because of medication improvement, or use of statins, or better antiplatelet drugs, and better guidelines directed levels for LDL cholesterol and hemoglobin HbA1c and blood pressure. So this is not our benefit, but is medication benefit. And indeed, it's true that in out-of-hospital cardiac arrest, among all the cause of and the etiology, the ones who has the better survival, albeit still low and below 15%, is still the cardiac disease. So there is benefit that we can catch up in our patient. And that's why the American Heart Association came out with this recommendation about building shock network and out-of-hospital cardiac arrest network on top of the available STEMI networks. And the sentiment is mostly the same in the European society guidelines. So we have, of course, randomized control data too that show that basically we need to revascularize our patient in cardiogenic shock. And this is already the late 1999 trials that everyone of us already know. But there is even a nice publication done in the European Heart Journal a few years ago by the German group of the FIT STEMI registry that were showing that in shock and out-of-hospital cardiac arrest patient, again, the contact to balloon time is fundamental. The higher the contact to balloon times, the highest the mortality, and the steep of the mortality is much higher for shock and out-of-hospital cardiac arrest than the normal patient. So we need to do something for this out-of-hospital cardiac arrest, and we need to do it very fast. And we already reviewed the new era of negative randomized control trial in cardiogenic shock and out-of-hospital cardiac arrest. The Tomahawk already show us that if you have a out-of-hospital cardiac arrest and not ST elevation MI, you don't have to rush in the cath lab. The ACLS shock has already been discussed, and it was a negative trial. But even last year, in the London group from our colleagues in London, they published in Lancet this study, which is called the REST trial, which is not the same study done in the US about ECMO, but it's the patient with out-of-hospital cardiac arrest were randomized to standard treatment in a standard hospital setting or transferred to a cardiac arrest center. And basically, there is no difference in survival, even if they are managed in a more advanced center. So Of course, in this patient, the out-of-hospital cardiac, in this study, the incidence of out-of-hospital cardiac arrest is much higher, 100% in Tomahawk and arrest trial, but we already see the in ACLS shock already was 77%, and the neuro death or neurological injury is so high that we cannot suppose any benefits, of course, because we know there's not that much we can do when patient has severe brain damage. So we cannot continue to think about out-of-hospital cardiac arrest and shock as a single entity. This is a very diverse patient with diverse need. And we already know that cardiogenic shock has different phenotyping. And on top of this, we add neurological damage of the out-of-hospital cardiac arrest. So classification, stratification, is fundamental when we want to utilize this very expensive treatment. So not every patient should go in cardiogenic shock center because the outcome will be neutral and you will spend money for nothing. But we have to personalize the medicine, stratifying this patient and not giving one side fit them all treatment strategy. For example, I heard many, concern about, okay, the danger shock did not include a comatose patient or not that many out-of-hospital cardiac arrest. I think that's why the danger shock was a positive trial, because basically they nailed the issue of treating the cardiac disease, avoiding to have any confounder by the brain death. And indeed, even if you go and look at the meta-analysis, with STEMI cardiogenic shock, removing the hypoxic brain injury patients, you still see an advantage of using mechanical circulatory support, either Impella, ECMO, tandem heart in this population. So, prognostication, when you ever receive a call, or at least in our shock network, when the shock team is activated, the first thing we do for out-of-hospital cardiac arrest, we stratify the neurological damage. You can use many, there are many different. I think the Miracle 2 score is the most studied and the most fitted for this population. If patient has more than 5, we don't treat it, we don't accept the patient in our center. The same is for cardiogenic shock. We want to know which is the cardiogenic shock class of this patient before arrive to our center, and we have a uniform. We need consistency with the data, so we use the cardiogenic shock working group app to stratify the cardiogenic shock level, so we are all of this on the same page. Because it's important to remind you that there is a golden day for cardiogenic shock treatment. If we treat aggressively in the first 24 hours and we can reach stabilization in the first 24 hours, we can do the difference. We can really reach the difference. And there is this notion of the door to support time. I think you will hear more and more about this one. So the door to support time is the time that passes from door in a cardiogenic shock patient to the active unloading device or ECMO device. And indeed, if you look at the recovery tree post-approval study of the Impella CP in AMI cardiogenic shock, you see that basically patients that were stabilized in between 24 hours have the highest survival, up to 75%, even if they presented in a E-shock class. And there are, of course, best practice to reduce mortality, which is pre-PCI implant, try to reach dorsal support below 90 minutes, achieve T-3 flow, use of Swan-Ganz catheter, and unfortunately, it's difficult for all the 4 best practice to be done in everyone, and even in their study, only 10% met this one. So to finish, I'm going to finish shortly, it's important to stratify your patient. You need a definite algorithm to treat those patients. One single physician cannot do anything. This is a multidisciplinary theme address of the problem, and you need algorithm. Without algorithm, you cannot treat your cardiogenic shock patient. You will not reach that level of survival that you can see in some registry. Just to finish, this is one case of last month, sorry. This is an inferior STEMI, 90 minutes of chest pain. You can see already there are Q waves in anterior. So patient, this is what looks like our STEMI time tracker when we do our monthly meeting in our network. So door in, door out, 15 minutes. Patient in cath lab up to less than 1 hour from arrival in the referral center. Then after, even during the puncture of the arterial, of the femoral, of the radial artery, patient went in VTAC, then VF, then finally PEA after 5 minutes of the first VTAC. So in our cath lab, we have a PA code and ECMO code. And after 5 minutes, we activate the ECMO code, and finally cannulation in 12 minutes. So I'm sorry I cannot show the video of the case, but that's
Thank you very much.
Thank you.